I tried to talk to my 91-year-old mother this morning, and she did not want to hear anything I had to say because it was all bad news, and she just doesn't believe it because she believes Trump's picture of everything is rosy. But that's enough of that.
You know, the horrible thing is that's terrible for public health. You know, if we have 35 or 40% of people doing the wrong thing, this isn't going to work.
Right.
You know, we really need about 90% compliance.
Well, she's locked in her assisted living center, so she's being compliant.
She doesn't have a choice.
That's right.
So I thought I'd do this because a lot of us aren't doing anything else anyway.
Right.
And I've been wanting to talk about what we're going to be doing in the near future and next year as well. So this seemed like an opportunity. I kind of wanted to find out how people are doing too.
Are other people coming in? Are you expecting others?
I don't know. We'll see. We'll wait a few minutes.
If you're short,
All right.
It may just be a short chat.
Okay.
Yeah. The ADA has been going crazy busy.
Hi, Martha. Sharon.
Hello.
I have to tell you, my teeth feel good.
Okay, good.
It's nice to be able to brush and chew without having it hurt.
Yes, thank you very much, Martha. I'm
You're
glad.
welcome.
I'm glad we got that done before this all went haywire.
Yeah, no kidding. Because I don't want to be caught doing the wrong thing.
Yeah.
So are you staying in touch with your residents, Dave?
Oh, I still am working at OHSU. I have to. I have didactic duties, so mostly I'm doing it like this,
Uh-huh.
and then I'm there. I'm there doing clinical stuff half the time anyway. But we have all the PPEs, so we're doing it as a team in hospital dentistry.
Yes.
So we've got Carla Kent, head of infection control, right there with us. Make sure everything's going. Karen Raplogel is our, well, kind of chair of the emergency team. She's chair of endo. Good leader. I like working with her. And we see emergencies, and we have heavy duty screening. We have N95s. We have the hospital available to us if we need it. So it's a different way to work. We're checking each other's temperatures twice a day. We have a whole protocol of how you have to use your PPEs. We practice every morning, putting on, taking off. It's really different than what most people are used to.
Yeah, sounds like it.
But I don't see that we have much choice if we want to see patients.
Right.
You know, I pulled this off the John Hopkins site this morning, and finally the U.S. is starting to do serious community testing, just barely starting. We started it 2 days ago at OHSU, where, in fact, the guy that I usually work with, now we don't see each other now. I only talk on the phone. He wasn't feeling well, so he went over and got a test. So we'll see what happens with that.
How long is it currently taking to get the test results back?
Well, at OHSU, they said 2 to 7 days. I don't know why it's 2 to 7 days. That's kind of an odd number.
Yes.
Probably they're figuring that the volume will tremendously increase pretty soon. So I'm pretty sure we'll get that result back in 2 days. My neighbor across the street, however, he runs a courier company, and he was hired last week by this company out of Ohio to do door-to-door testing. So what his couriers will do is they'll get an address, they'll drop the test off on the doorknob, and then they'll come back 4 hours later and pick it up. And people are now, I've heard that some of these new high-tech tests, you can get the result in about 40 minutes once they have
Wow.
the thing in hand. Well, there ought to be no reason that it takes so long. So anyway, I expect that these numbers are going to get enormous, really big, in the next week or so. I mean, as you can see, the U.S. has the most cases of anybody now. Unfortunately, it's because we've been careless and haven't prepared, and we've not
Right.
been doing any testing until like 2 days ago. I mean, not
Right.
really. I mean, to say that we've done 20,000 tests or something, that's a drop in the bucket.
Right.
So, I mean, I'm looking at these numbers, and I think they're many times bigger. Italy's got a sad situation for a country with only, what is it, 40 million people?
Mhm.
Look at how many cases they've got. But they're doing more testing than we are. Then you know what? Korea has fallen off the numbers. I don't even see them on there anymore. Oh, no, it's at the bottom there. Yeah, they were doing really extensive community testing so that they could put out fires and target. So they seem to have gotten a handle on it. And now China, although they've kind of are coming back to life, they're having to be really careful with reinfection and this thing coming back. But they've got an extreme high level of surveillance. I mean, they've got facial recognition. They track people by their cell phones. If somebody comes up sick, they know exactly where they went and who they saw.
Uh-huh.
So they can track everybody down. I'm thinking we're not going to do that.
Yeah, probably not.
So if we're relying on compliance voluntarily, boy, I hope we do. Because like I said, if 40% of people don't comply, it's going to be a real problem. You know, sadly, this at noon, the state dental commission for Washington, we're going to see the first complaints about people that are doing elective procedures during this pandemic. Now, because the governor made an executive order, I don't know what it is in Oregon. In Washington, it's a gross misdemeanor if you violate a governor's executive order in an emergency. Is it a gross misdemeanor in Oregon?
I think so.
Okay, well, in Washington, that means that they can put you in jail for a year. And if it's clear, they probably will. They can also levy a fine, and then it would be brought before the commission too. We would probably end up looking at it first, and we would have to determine, is this actually an elective procedure or was it an emergency? If it was elective, then what we're supposed to do is it's $5,000 per incident each time it happens.
Wow.
And we can go all the way up to removing their license. And we may not have a lot of leeway. It's
Wow.
it's just crazy. I don't know how heavy it is in Oregon. I'm not part of their board, but I think they'll take a dim view of it too.
I imagine they will.
Are you guys hearing about people out in the community doing elective stuff?
I'm not right now, but I'm going to be on another Zoom meeting this afternoon through Oregon Academy of General Dentistry, where we're going to be talking to some attorneys about the FRLA that was passed 2 weeks ago. So I'm trying to keep up with some of the science of it, but obviously I'm also really scrambling, as all of us are, on the business front too. I was advised by my financial advisor to keep my staff on if I could and not tell them to go on unemployment. So,
Oh, no, what's the reasoning for that?
so that when it's lifted, we can be up and running in a minute, and they can keep their benefits, their medical insurance, and that sort of stuff without having to go on whatever the long-term thing is.
Well,
The other reason is that employers pay all the unemployment.
so what happens if we are off until June 15th? Like even I'm predicting, I don't think we're going to have a come back to practice in the middle of June, not looking at the epidemiology.
Last Monday, I spent 5 hours on the SBA website applying for a loan. So I'm somewhere in that line, but it has not passed the House of Representatives yet. I just read that a rogue GOP person wants everybody showing up in person. So that may be delayed until tomorrow. And I read in the New York Times this morning that even when that passes, the funds won't be available for like 3 weeks.
Which is pretty
And
fast relatively.
the salaries are supposed to be reimbursed by the federal government.
Really?
Yes.
Okay. Well, that would be good if we could keep our people together. Wow. Well, then the other question is, are the patients going to be so scared? Are they going to be willing to come in? And will we be ready with the proper PPEs and training? Sounds like that's a job for the AGD.
Well, yes, maybe for another day. My building downtown is locked up.
Oh, you can't even get in the building.
Well, I can if I had to, but not the general public.
I see. Huh. Yeah. I don't know. We're going to be looking at these complaints for the dentist today. I'm not personally, but I'd have to look at them next week. And so the people that are locked up, I'm sure, are unhappy with people that aren't.
Yes.
But I don't know if anybody really realizes that this could mean prison time.
I doubt they do.
Well, unfortunately, that's not going to be an excuse. I don't know. It puts us in a really terrible position.
How many complaints do you have?
Pardon me?
How many complaints are you looking at?
Uh,
Or is the board?
I won't know until next week. The manager at the Department of Health told me she just said they're a bunch, which now usually we review maybe 15 or 20 complaints a week and throw out most of it. So if she's saying it's a bunch, it's probably more than that. I don't really know. They had a concern that they were going to be flooded based on all the phone calls they were getting from people that have closed their offices and tried to be responsible and follow the rules. Because they're pretty upset that other people are just continuing to work. Apparently, so this is I'm hearing that PSOs that are continuing to work. I don't know if that's really true. Bob Kravitz is on. Hey, can you hear me, Bob?
I can. Good morning.
How you feeling?
Fair.
Oh, okay. How's that fever?
Yeah. Still waiting to hear results.
Okay. So how easy was it to get in to get a test, Bob?
Simple. There was no one else in line.
Huh. So anybody that's on the OHSU insurance can just walk up? Or how does that work?
It was drive-through only.
Drive-through?
Right.
You had to, what, spit in a cup or something?
No, they swab they come over to you all, all properly isolated, and they swab your throat.
Ah, I see. Okay, well, I'm crossing my fingers.
And results in 2 to 7 days.
Hmm.
Bob? Hello?
Yes.
Make sure you let us know if you do test positive, because you were in the last meeting with us, I remember.
I certainly will.
Thank you.
Yeah, the typical incubation is about 5 days, but it can be much longer, as we all know.
Hey, Dave,
Yeah?
even if people aren't caught right away, they could be audited later on.
Yeah. Well, we need to keep track of contacts to be safe.
I mean, as far as working through this pandemic.
Yeah. Well, were you on when I was talking about what the commission is doing, Steve?
No,
Yeah. So we're in kind of a bad spot as far as this is, because this is the governor's emergency proclamation. It carries a penalty if you're in jail to do things that are not elective or to violate in any way. It can include a fine, and probably the people that are going to have to determine whether it was elective or not are going to be whatever commissioner the case would be assigned to. So Aaron, our manager at the commission, said we had a bunch of cases to review. So they're reviewing them at noon, and then I get to review them next Friday. This is going to be pretty terrible if a lot of people are doing this, because they could actually go to jail.
wow.
Yeah, it's no joke. So I thought I'd take a look at what people have heard about as far as solutions. So I'm sure you've heard about this stuff about chloroquine and hydroxychloroquine. Are you guys familiar with what that comes from? So there was a story about some chloroquine phosphate, which is a fish tank cleaner, and died. Yeah. And apparently the wife survived and said, "Don't listen to Donald Trump." So anyway, there is some basis on this. Antibiotics seem to have some effect on this virus connecting to the receptors, and it can disrupt some of this. So chloroquine and hydroxychloroquine are actually synthetic versions of quinine. So it kind of makes you think that gin and tonic is kind of the drink of the quarter, because tonic water has quinine in it. Hard to say if it would have any effect or if the dosage would be anywhere near enough. I think most of the cans of tonic water only have about 10 milligrams. I don't know what the equivalent is for hydroxychloroquine. Usually, if you're going to take hydroxychloroquine, it's like 500 or 600 milligrams per week, and you take it all as one dose. At least that's what I've read for prophylaxis. One of the problems too is that you probably can't get it. It's mostly used for people that have lupus or rheumatoid arthritis, and many of them usually get like a month's supply or maybe 3 months supply, and they're having a hard time. Some of the physicians are sequestering this to make sure that it's available if they do indeed find it is helpful for people with COVID, but there are a lot of people that are dependent on those drugs. So anyway, like I said, it probably won't hurt to drink tonic water. Has anybody heard anything else about other drugs? Because all I've read are case reports mostly, or talks about clinical trials and nothing's really worked out yet. Other than maybe somebody saying a case report, the patient recovered, but we don't know if it recovered anyway.
Right.
So the other thing that I'm hearing about the vaccines, there's a whole slew of companies that are trying to come up with a vaccine. Let's realize that MERS and SARS, they tried to come up with vaccines. Coronaviruses are really tough to be able to come up with an effective vaccine. So neither the MERS vaccine nor the SARS vaccine got past the phase 1 trials. Normally, a novel vaccine takes about 5 years. So this talk of a few months or even a year, I'm puzzling over it. I watched there was a WebMD continuing education video where they interviewed this Dr. Gordon from Mayo Clinic, who's worked on vaccines for 33 years. And he essentially said it's a pipe dream to think that it's going to be available anytime soon. So
Dave?
we're left with stopping transmission and following the governor's orders. So I'm still looking at the epidemiology of the R0 of 3. Unfortunately, if we're uncontrolled, if people keep seeing other people, it's going to be a lot bigger than that, where people can expose tens or hundreds of people. Fatality rate, now, if we're really on top of it, probably going to be about 0.7%, like in Korea. I think that number is driven a little bit, but if we have uncontrolled transmission, a couple of MD friends of mine say that we could be upwards of 5 to 7% mortality over 12 months. So it's really a big deal that we get this under control and do extensive community testing. So without intervention, manage 50 million people, at least, maybe 100 million. So they tried different things. I mean, the quinine didn't really seem to do anything for them. I think the dry champagne, not a bad suggestion. It might have something to do with this coronavirus. So they didn't recognize the cause until 1940 with the invention of the electron microscope. On the other hand, the Chinese very, very quickly. So we know what we're dealing with. It's just that this is a tough critter because this thing is in the Goldilocks zone of pandemic viruses, where it has just the right mortality and just the right transmissibility that it's going to be very, very difficult to control. So even the Chinese, who have kind of gotten a handle on it, they're still struggling because they can get reinfections and spread. But they do have the advantage of hyper tracking. They can do facial recognition. They can recognize what's going on quickly. So what we're doing at OHSU is we're following the governor's executive order. And I know the Washington Commission and the board are going to start dealing with sanctions. Well, not sanctions, but dealing with cases today. And going to start figuring out what to do with these things every Friday from here on out. The Washington Commission does that weekly. I hope everybody's doing screening. If you're seeing people at OHSU, that's what we're doing. We have multiple layers of trying to screen through patients to make sure that we're not going to expose ourselves or other people.
Hey, Dave? You're getting a lot of background noise. Wondering if everybody could mute themselves until they want to say something.
And if you want to say something, just say, "Hey, Dave," but please stay muted for the moment. So we're screening for anybody that has a fever of 100.4 or more. What we're asking them if they've had any contact with people that have COVID. I now know 2 families that I've been in not personal contact, but phone contact with people that I've known for years. I haven't seen them any time recently, fortunately, or unfortunately, but in this case, fortunately, the whole family got it. So, no, that didn't come out right. Anoxia, no, it's anosmia. one of the symptoms that you may want to look for when you're asking people is an inability to smell. So it would seem that we're coming up with that as a screening criteria more and more. Anosmia, which means you can't smell, or you can have altered smell, or you can have altered taste. And so if people are saying, you know, I have some of these symptoms, but they have altered taste or smell, then that would also be a signature symptom that you've got to take seriously. When the patient shows up at OHSU, then the staff screens them before they even come into the building. We've got a security guard down at the bottom. One thing I wanted to mention to everyone is that OSHA has emergency rules now that if a staff member is not wearing proper PPEs, that it would be an OSHA violation. So proper PPEs for any kind of procedure that would produce aerosols, that would be an N95 or greater. And why the N95? It's because it has a seal. So level 3 mask has the same filtration and water resistance. It's essentially made out of the same stuff, but it doesn't have a seal. It doesn't seal tightly to your face. So what are we finding about N95s? Mostly I find they're just kind of hot. It gets kind of moist underneath the mask. But we don't really have much choice. Either if we don't use them, we can't see patients. I think when we come back to practice, though, the aerosols is going to be such a big deal. And we're going to have to examine what we can do about our infection control standards. I was wondering if anybody out there has comments.
Dave,
Yeah, John.
one time you mentioned about a salt layer
Yeah,
between the
that was a Korean mask, and it was done as a prototype. So the purpose of it was to kill influenza virus. I would imagine it might work for this. So the idea being that the viruses are going to come at you in little water droplets, and it would go into the mask and hit this salt layer, and that would dissolve. It would be very salty, and then it would gradually dry out again, and that would kill the virus. So I haven't heard of those being available. I think it's a clever idea, but I don't know if it would work on this or not. You would think it would, maybe, but I don't know.
Hey, Dave.
Yes, Steve.
My understanding is that the N95 mask is just for known COVID-19 patients. And, you know, we kind of went through all this with HIV back in the 80s where we double gloved and put HIV patients in separate rooms and all sorts of weird things. And I'm hoping that when this comes down, that we'll be back to just regular universal precautions and everybody's just more careful about taking off their regular mask, and they're only good for about 20 minutes anyway. So
yeah, unfortunately, the OSHA guidelines that I read said that if you're going to generate aerosols, you have to wear an N95. At least your employees do. What we found, or what they found in China, I'll give you an example of an aerosol producing procedure. Now, this was from an ENT office in Wuhan, where they were doing a pituitary tumor. And so it was in a hospital. They had 14 people in the room that were at varying distances from the patient. And they did the procedure without N95s. They just had, I believe it was level 2 or 3 masks. Every single healthcare provider in that room got sick. One of the problems with this virus is that we don't know if people have it, but they can be shedding virus. So the only really distinctive thing about an N95 or these other higher level masks is the seal. So it would appear that at least for now, if you're going to produce aerosols, you've got to have some kind of mask system that has a seal. Now, if you're not going to produce aerosols, you don't. So then even a simple surgical mask ought to work.
So this is something new.
Yeah, well, these OSHA guidelines kind of put a big damper on that. And these are the guidelines that the Chinese have followed, and they had some success where, see, once they realized in Wuhan what was going on with this and the high risk of the aerosols, they went to only emergency procedures in dentistry. And if you were going to produce aerosols, you had to wear an N95. And after that point, no dental, this is what they told me. I've asked them directly, a medical group in Shanghai. And they told me after that, no dental personnel got sick. Now, what I'm also on a chat group with dentists across the country, and they were asking about, okay, are dental personnel getting sick? And I started just getting a flood of people saying that, oh yeah, my neighbor who's a dentist, and my colleague and my classmate, and apparently they're a bunch.
Greg, this is John. That paper you sent me yesterday,
Yeah.
yeah, can you give us a little summary of that?
Did you read that, Dave? That study from Wuhan on the dental school up there?
No, I didn't. Could you send it to me? Can you tell us what the gist of it is?
So they had a whole recommendation of how to treat patients, which is basically what you're suggesting. It's have the patient wait in the car till they're ready, bring them right into the operatory, get rid of any unnecessary potential fomites in the operatory, be gowned and gloved and ready to go. Limit your aerosols. Don't use a high speed unless necessary. Use a rubber dam as much as you can. But he also said in there that by occupation in Wuhan, they determined who got the virus the most. You know who's number one?
Who?
Dental hygienists.
Yeah.
And followed closely second was dentists. And at the very bottom was loggers. So be safe. But anyway, it's interesting stuff. What I've been doing, I've got a limited number of N95s and I reuse them, but I'll put the level 3 over the top of it so I'm not touching that mask ever. Just put it on and off. I don't know how many times you can use it before it's ineffective, but I figure.
So one of the concerns, what they told me from the folks in Shanghai is they said that the most common way that a dental provider would get infected was by touching the outside of that mask. Because if it's working, it's going to get the virus across the outside of it. And so you had to be very careful about how you removed it. So Sarah Gordon and I, Sarah from the University of Washington, we've been talking about what will we do if we run out of N95s and have to reuse them if we have no choice. So there's some strategies you could take. The virus will die at 56 degrees Celsius if you leave it at that heat for about 30 minutes. Another approach, I think University of Nebraska was talking about how you could expose it to UV light. So UV will kill just about anything. So if you expose it to a fairly intense UV light, that should sterilize it. Another approach is simply leave it in a warm, dry place for 5 or 6 days or a week. That would kill it too, because we have to realize that this virus has a lipid bilayer, and anything that can dissolve that lipid bilayer or cause this thing to not be able to maintain itself will kill it. So leaving it on a brown paper bag would kill it within hours. So it's actually fairly fragile. It's just if it makes this transfer from something damp like a droplet to mucous membranes, then you're cooked. So are you able to rotate your N95s? Or are you doing something with them to keep them clean?
Well, I'm only seeing, I think I've seen 3 patients this week, so I just put that other mask over, try not to touch the N95 and just leave it there to dry. So it doesn't ever get wet other than from my own respirations, you know.
Yeah. Well, I would certainly consider, I mean, if you have access to a UV light, or if you can, I wouldn't want to warm it by shooting a hairdryer on it. That was one paper that came out of Shanghai, was somebody that was reusing masks, but they were testing it for flu virus. So what they would do is they would put the mask in like a baking bag, seal it, and then they would run a hairdryer on it for half an hour, and that seemed to do the job. But it also occurs to me you could probably put it in an oven on low. And I mean, we're talking about situations where you don't really have a choice. I mean, obviously, the first choice would be to use a new one. We may not have that choice.
I could take it to the tanning salon across the street. They're closed anyway. I could just use their tanning beds.
Maybe you ought to call them up. Lay the masks out in there and tan them. Yeah, that ought to work.
How about the old curing lights?
If you have one, I mean, you're talking dating back to the early 80s when they were still.
Yeah.
Yeah, I mean, people used to get sunburns from those things. I would think that would work fine. It's just that, you know, you're gonna have to run it across that mask little by little. Oh well, maybe something for staff people to do that have nothing else. So before I move on from this, are there any other questions or discussion about COVID-19 and SARS-CoV-2?
I've got a question. I came in, you were talking a little bit about what's going on up in Washington. If there's people that are still working, performing procedures as normal, I understand. It's difficult for us here in Oregon when the date is June 15th, and I've got patients out there with temporary crowns on vital teeth. They're not going to last 3 months. So if I bring these people in and seat a crown, is that considered a no-no for the next 3 months? I'm concerned these teeth are going to start bothering and go non-vital or need an endo. You understand what I'm saying? It's a difficult choice I'm making.
I understand exactly what you're saying. So I don't think we've gotten really great guidance about what a true emergency is, other than it's starting with the principles of medical emergency, where uncontrolled bleeding, pain that interferes with daily living, fracture of bone, abscess or some kind of cellulitis into soft tissue. If it falls within those categories, it's easily defendable. I guess the fuzziest one is pain.
Well, the other thing that was on Governor Brown's order was if delaying the treatment would cause irreparable harm to the patient. Well, if you could put a crown on and prevent it from needing a root canal because you left the temporary on for 3 months, couldn't that be argued? I mean, I don't know.
I think it's arguable. Boy, you know, I'd want to ask the Oregon board how they felt about it before I jumped on it. But I think if a temporary came off and a patient's uncomfortable, I think you would have an argument that you need to do something about it. And putting the permanent crown on would seem to me to be a defendable thing to do, because then they're likely not going to have to come back again, which would be more transmission or potential transmission. But ultimately, you're going to have to ask the Oregon board if you're unsure, because they're going to be the arbiters of was this elective or not.
Excuse me, Dave, Keith here.
Hi, Keith.
And I have the ADA's guideline for COVID-19 for what constitutes a dental emergency up right now, and would be happy to screen share where it actually includes urgent dental care, allows final crown bridge cementation if the temporary restoration is lost, broken, or causing gingival irritation. But
Well,
I'd be happy to share the document.
why don't you, I don't know how do I share that?
Well, there's somebody else sharing a screen now. If somebody stops sharing their screen, I can share this screen.
I think the only problem with that, Keith, is that's been kind of superseded by the mandate here in the state of Oregon from the governor. That was spelled out, all those things were spelled out on her sheet, but there's still a lot of room for interpretation on that for sure.
Yeah, we had something from our governor too in Washington, but this was published on March 19. And what I'm reading from our governor's proclamation is, I think we could do these things. Now, they also invite people to make a request to review something on the governor's site in our state. And I think I may upload this to them and see if they want to change anything from this.
Yeah, why don't you email it to all of us, Keith, and we can look at it. The thing is, the arbiter, well, we're going to have to talk to the Attorney General. I'm talking about the commission. So we're going to have to talk to the Attorney General, and then we're going to end up the arbiters of what is emergency or not. So
I also wanted to comment. I took some extra gloves and masks over to a drop site here on Monday. It was at the ODS building in Milwaukee. And the gal that I dropped him off to is, I don't know what her role is there, but she said they're going to start looking at what people are billing. That's how they're going to catch you. So if you're billing out pro fees and exams and restorations, that's an easy way to trip their red flag that you're practicing outside of what the intent of that ruling is. So I think, if it's 1 crown every 2 weeks is probably not going to raise an issue. And I wouldn't think as a board member, that's something you're looking for. You're looking for somebody who's doing something egregiously wrong and not following the intent of the governor's ruling. Anyway, that's my 2 cents.
well, what I'm hoping is that people are going to carefully document why it was necessary treatment. I think the commission, our Washington Commission and the Oregon Board are going to have to look at it that way. Is this documented properly that this was really something that needed to be done, and not just, oh, the patient was coming in and I needed to do those fillings. It's, really their touchstone is going to be what is medically necessary. But pain is considered a criteria of an emergency. So if a temp comes off and it's uncomfortable for the patient, bothering them, or they're having trouble eating or something like that, that's definitely a reason to do it, to take care of it. But I would carefully document why it's being done, why and how it falls within the range of emergency.
I'd like to point out that I'm working with UW School of Dentistry on their teledentistry systems they want to introduce for their emergency department and their hospital dental program. So they convened 10 people for a slide presentation I made for them about teledentistry on Wednesday. And we covered all kinds of things about forms they need to use for the special consent for teledentistry, ways to be able to pass forms securely by email with patients in a HIPAA compliant way. We covered some ideas about what a protocol can be, but this is going to be one way for them to screen patients before they come into their emergency dental facility. And I've done that for 2 patients this week already now, where I'm using Zoom Pro Health. It has to be Zoom Pro Health with the patient because it's encrypted. And you can work with a patient to get pictures from them to show their condition. I've been working up ways to interview a patient using the template for a limited exam that's in my patient chart system. And there are a lot of things we can determine. And so fortunately for both patients, we're able to determine they had conditions that can wait till after March 18th or May 18th. But that's also a way for a dentist to not only help with their responsibility to a patient, but it's also a way to help build your schedule so you have something to come back to later.
That all sounds good, Keith. So what we're doing at OHSU at one of my residents, Kevin Chung, is working with Upper Campus to try to see if we can get some of that going at the School of Dentistry. So maybe we can create some protocols. Maybe have you been in contact with Kevin on that?
Yes, I have.
Yeah.
And most of what he had was about systems where they had hygienists in nursing homes that were doing review of patients, observations, perio charts, and uploading the information for review by a dentist. Well, a part of the work I'm doing with UW is to create a regional dental referral system where it extends from general practitioners who can say, I want to refer a patient for whatever reason, through our CORA in our state. If somebody wants, they have a dental referral line. It's just a phone line, an email where a patient says their chief concern. But what I'm striving to do is to help create more or less a standard way where a dentist can accumulate information and do something of a case presentation or a bundle of patient information to pass up to someone else, and ultimately to a hospital dental clinic if referrals necessary. So I'd be happy to include Oregon in the same effort as UW. And we've got a few different resources like a secure email client that can be used, how to use Zoom Pro. A stumbling block is the expense of Zoom Pro Health, which you have to subscribe for $200 a month to get a number of licenses. And I'm really hoping that we can see some help from our associations to get us the license for $20 a month each or less. That would really help for dentists that wish to participate.
I think that would be a great idea to help everybody. We've got to maintain contact with our patients, and we've got to
sure.
Screening. We can't let everything just linger. It's not good for the patients. It's not good for the dentists. It's not good for anyone. What I've been doing is I've been trying to connect UW and OHSU on on doing a little bit of teamwork on how are we going to deal with didactics, how are we going to deal with protocols, how can we, anything that we can where we can share information to try to make this a better situation. And I think that's a real positive thing to do, just like getting on here for a little while and sharing what we know. It's a huge problem. It's not going to go away quickly. I'm hopeful that it'll be under control by June. It's going to take some real effort to just do that. And if you've looked at the numbers this morning, they're pretty big. And we're just starting community testing. So they're going to get much, much bigger.
The mayor of New York City announced this morning that he expects half of the population of New York City to become infected.
I think he's being optimistic. I would be surprised if it isn't a bigger number than that. So I think that would be a conservative estimate. And that's where I get really worried. If half the population of New York City gets infected, which is, I don't know what the exact number is, around 20 million people, that would mean that all our ICUs will be overwhelmed. They won't nearly have enough ventilators. And that means savable people will die. So that's when you start getting into the realm of 5% of people that get infected die. Of course, that's not the end of the world, but that's horrible. So if you're talking about, go ahead, Keith.
Another interesting point was made that the deaths don't necessarily occur directly with virus infection in cases where the resources are so slammed that a heart attack patient who would have had an ambulance in 8 minutes with an emergency room, a surgical suite, a doctor, an intensive care room, won't be getting that. And instead, within 50 minutes, that patient dies.
And that's why some people are predicting 7% mortality.
Wow.
So
This concept for a regional dental referral network is the idea that we coordinate the school resources with the practitioners, with our association at the state level for the dental associations and at the community level for the components. If we can work together to create a network, make the resources known, help people to get to the resources they need to be able to make a referral or be visible to the public when they need it, to try to keep people from just showing up at dental emergency clinics and offices when we're afraid of contagion and we want to screen the patient to see if they really have something that we need to see. So with both of my patients, as I said, I served them, but we determined they did not need to be seen. So I'm happy to help contribute to that for Oregon as well as UW. I think that we can make progress with the websites that are hosted by the ADA for component dental societies. I think we can make mention of it in MailChimp campaigns to member dentists and the rest of the dentists. So one of the things at our disposal is the Aptify database at the ADA that includes the best information we can get for contacting all of the dentists, not just members. And I see an effort to try to include non-members in a lot of things just because, you know, and especially if they don't have the money to blog, that's going to get worse.
Mm-hmm. Yeah, you're right. So, as Benjamin Franklin once said, if we don't hang together, we'll certainly hang separately. I don't think this is going to be solved by any one person. It's got to be a team effort. We're all going to have to work together. I think University of Washington, Oregon Health Sciences, the state of Washington, the state of Oregon, and our components, we're all going to have to work together to make this work at all. It's not going to help anyone if we can't treat emergencies or we all go bankrupt. It just doesn't make sense. One thing that I worked on a little bit is trying to find a source of N95. So I did through Laura Jordan, my physician friend who works in Shanghai. She does have a source of N95 masks. And so I've tried to send that contact to various people. I know some organizations are reluctant just because it's China. But shoot, they make an awful lot of stuff that we use. This company is providing N95s to Italy and other countries in the EU. The downside is of this is that any one dentist probably couldn't do it because the minimum order is $25,000. On the other hand, the masks only, apparently the cost is even less than I thought. It's less than $2 per mask. But it's a problem if you have to make a minimum order. They say they can get it here in 1 week. So I suppose if we get desperate enough, we may be talking to them.
Dave, are we supposed to have the N95 masks now for treating all patients? And if so, how would we get an N95 mask now?
That's extremely difficult. So one of the things I mentioned is that by the emergency OSHA rules say that you can't let any staff members be in a procedure where it produces aerosols unless they have an N95 or greater to protect them from the aerosols. So we're between a rock and a hard place where the governors are saying we need to deliver ones we have, or at least anything spare. They're almost unobtainable, at least from US sources. Yet we could get them from China. So it's really a quandary.
Have you let the governor's office know about this? Because he's actively seeking that, according to his broadcast yesterday.
Yeah, I sent an email to the governor's office. I don't know if that's taken seriously. I also sent a message to Eileen, or the head of the Senate Healthcare Committee.
Uh,
I was going to say Eileen Cody. That's not right.
That'd be Annette Cleveland.
Annette Cleveland. Yeah, so Annette Cleveland, I sent that message to her as well. I talked to the mayor of Vancouver, but she said she can't really deal with that. Send it to the health department. But I'm afraid the health department's probably getting a million emails right now, so it's kind of probably dust in the wind. I can send it to you, Keith, if you have a better way to get contact with people.
Well, every now and then something happens, you know. I can bang around. Please do.
Yeah, I also sent it to one of our trustees with the ADA, but they kind of shrugged and said, well, the ADA doesn't do that kind of thing by masks, and they weren't too sure about, getting masks because they'd have to test it, and the minimum order was $25,000. So anyway, that kind of went nowhere. But the trustee said she would keep it in her back pocket.
Mm-hmm. Well, you know, I just put up another email, or actually web page address in the chat window that we have for this conference. And this one is to Delta Dental of Washington. And they are actually doing grants up to $15,000 to member dentist practices if they're in need. And they've got another program where they've got loans available with a long-term payback up to $25,000. So with a $15,000 grant, $25,000 loan, well, $40K might be enough to carry somebody through the next 3 or 4 months, where at least in my practice, I don't expect to have a net income. And so I'm fortunate I can, you know, use my credit lines and other resources, but for a lot of practitioners, they don't have that elasticity. So the grants are focused more for those who actually have need. But I think it's wonderful that we can point to something where some of our practitioners will get help.
I agree. So we're getting close to the end of the hour. One of the things that I'd like to do eventually, maybe we'll have some more of these Friday meetings, brief ones. I would like to talk about what we're going to do with Tilikum next year. I would hope that we'll be past this, or at least mostly past this, by September. One of the things that we're going to be scheduling are the we call it the DIMET, where people get to see live patients and do emergency drills at the school in the sim center. We're going to set up some prototypes for September and October. I'm going to need to see what the interest is, how many people would be wanting to take that. We'll probably be including some faculty in that as well. That would be a separate fee aside from doing your Tilikum subscription. We're going to do everything we can to make sure that we keep the subscription low fee. I know that a lot of us will not be making very much money this year, and yet we still have to have continuing education. So I'm going to be thinking about that. If you could send me what you think you're going to need. Assuming that we're going to have a hard time getting much CE, at least live CE, how can we focus in on what your needs are? as well as we want to give it an interesting spread of what sorts of things are going to keep things lively. So I would welcome any suggestions. We may do this in another week or two. We'll see how things develop. Right now I'm trying to decide what platform we're going to use. At OHSU, they would prefer I use WebEx. And so I'm going to be working with EdCom this afternoon to see how that works, and whether or not we want to continue to use Zoom Pro or WebEx, and how I would work with EdCom on that. So that remains to be seen. I have to check in with some of our speakers over the next couple of months to make sure they're still going to be available. Mostly I would be concerned with my MD colleagues that we're going to be hearing from. I talked to Jim Hutt a little bit. I think he's okay with being on. I think other people will continue, and we'll have pretty much the same program, but I do need to check in with people. Are there any final comments before I let everybody sign off?
Hey, Dave, this is Steve. I just want to say thanks so much for what you're doing. Good news, the House just passed the $2.2 trillion stimulus for the COVID virus. And I can tell you the WebEx works pretty well. We've been doing our OHSU periodontal resident presentations on that, and it works great. So
okay,
thanks for what you're doing.
Got another thing to say. Splashtop is a very good system for doing remote access to your patient record systems from home. And it's very affordable. It's very, very full-featured and reliable. We installed it for 4 computers at the office and several staff members. And that's how I'm looking at patient records when I'm talking to them. Zoom, I think, is still better for working with a patient because you have the video, and it's HIPAA compliant if you use the Zoom Health Pro version. At the school, I would really recommend that they stay with Zoom Pro because it's integrated with the Epic medical record that's up the hill at the medical school. And so I imagine you can do some things with WebEx too, but Zoom is the one where we've got a better future for medical dental collaboration. So this is also a great time for us to ask everybody to please give us real-time access to medical records as dentists. We're going to want to see for sure if somebody's been tested positive or if they have other risk factors as we proceed eventually with dental care.
Thanks, Keith. What was the name of that splash? What?
Splashtop. SPLASHTOP.
Okay.
And it's $99 a year for a single user, but you can buy a license for 10 at a 45% discount. So it winds up being $55 per user. And if you'd like, Dave, I have 10 licenses. I can loan you a license if you want to test it and see what you think. You can have separate teams that don't communicate with each other within the same master license. The way I found it was there's a company that does dental insurance billing that has 6 staff members in Lake Oswego. They do remote access to the client dentists all over the country. 6 people work full-time doing dental insurance for dental offices remotely, and that is the application they use. And so on their recommendation, I pulled it up. It's really a nice idea. And my staff leader, my office manager, squealed with delight when she saw it work the first time.
Okay. All right. Are there any final comments? I should let everybody go.
Okay. Thanks a lot, everybody.
Hey,
Thank you, Dave.
I'm going to make this available with a private YouTube. So that should be up pretty soon.
So the Oregon Academy of General Dentistry is hosting a Zoom meeting this afternoon on the FRLA. If anybody here wants me to send them the link to that.
So what does the acronym stand for, Martha?
It's the emergency family medical leave that Trump signed an order about 2 weeks ago.
Okay.
And I think it's going to require us to give paid leave, although I don't know what the cutoff is for the number of employees, an additional 2 weeks sick leave and up to 3 months for taking care of a family member or with kids being out of school and that sort of thing.
Could you send that link to everybody on the email then?
I will try to do that, yes.
Another way to do it is click on the bottom where it says chat.
Yes.
And there's a window where you can put the link in the chat window for somebody to copy. So I've got a few links up there already.
Excellent. Okay, see you everybody. Maybe next week.
Bye.
Bye.
Okay. Bye-bye.
Bye.